We are live now, doctor. You can start
Yeah.
now.
Hi everyone, good evening. So on behalf of Rajasthan Ophthalmological Society, I welcome each and everyone you on board this session of Kaksha. So this is, we have it on the Zoom. We also have it on the YouTube, and there are certain places like Ajmer Medical College. They watch this Kaksha online uh, in a classroom. So we have a good number of attendance usually. So on behalf of ROS, I welcome Dr. Vanathi. Dr. Vanathi was my teacher, my senior resident, and I have learned a lot of things from her. So she's a cornea specialist at All India Institute of Medical Sciences, New Delhi. And today on Kaksha, we have two residents on hot seat. Ashima, she's a third year resident from SMS Medical College, and Dr. Sahil, he would soon be joining. He's a senior resident at the SMS Medical College. So we'll be having a nice interactive session on infectious keratitis. So over to you, Vanathi ma'am.
Yeah. Thank you very much, Ankur. It's a pleasure being here with all of you. And I think today's topic assigned to me by Ankur is looking at microbial keratitis at a level of what postgraduates need to know. So I think without much delay, let's directly go on to our presentation. I'm going to make it largely an interactive presentation. Ashima is here. Are my slides visible?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay. Right. Okay. So Ashima, I'm going to make it very interactive so that let's do away with the didactic part and let's discuss each slide. And I'll probably ask you what you want to know on this, or you can stop me if I'm speaking and ask what more you want to learn on this particular slide. Will that be okay?
Yes, ma'am.
Yes. Yeah. Okay. I cannot see Ashima. Okay. You prefer not to be seen, I guess. Yeah. Okay.
The video, Ashima, if possible.
No, it's all right.
Oh, it's okay. It's
Whatever
okay.
she's comfortable with, that's okay with me. Yeah. Okay. So now today's topic of learning would be microbial keratitis, diagnosis, management, workup of a case of corneal ulcer. So I think this is one of the most wanted in long cases, and it's also one of the most not so favorite topic among postgraduates where they don't like to look at corneal ulcers here. So I'm going to move on and show you this particular slide here. So here we have what we define as corneal ulcer. So what do you know as an ulcer? We all know is a discontinuation in the normal epithelial surface of the cornea, which is associated with necrosis of the surrounding corneal tissue. This necrosis is initiated by the infiltration of the microbial organism, which is affecting the corneal epithelium, stroma, or deeper tissues. And there is also a lot of collagenolytic enzymes released by these necrotic tissue, which is going to add on to further damage which is causing. So it's sort of a coagulative necrosis which is undergoing because of the infection which is occurring on the ocular surface, on the corneal surface primarily when you're talking about keratitis. So for those who are managing keratitis, what's important is first is you look at the stage at which the ulcer is presenting to you. So I think we all would have read in the textbooks the stages of the various stages of a corneal ulcer. So you have a stage of progressive infiltration, you have a stage of active ulceration, you have the stage of regression, and you have the stage of cicatrization. I'm sorry, the other two photographs don't seem to be coming up for some reason. And so as the name is indicative, it's progressive infiltration, which means there's active infection occurring on the ocular surface. The infiltration is progressing. So the ulcer is quite active here, meaning the organisms are dividing and the damage to the ocular tissue is actively ongoing here. And here you have the stage of ulceration which follows it. So the infiltration has caused a break in the continuity of the ulcer. It's spreading on to the adjacent layers of the corneal tissue and to the deeper layers of the corneal tissue and is also inciting an anterior chamber inflammatory reaction. So that's the stage of active ulceration. From there, it would move on to a stage of regression if the infection is being contained for whatever reason. either by itself or largely by the antimicrobial therapy which is undergoing. So the ulcer starts decreasing in size and starts healing. That's the stage of regression. The stage of cicatrization, as the name means, which where the scarring occurs. So the infection resolves and the collagen tissues have been affected. They heal by scarring. So there's opacity in the region you've had the ulcer. So this is the 4 stages of a corneal ulcer. And it's important to know at what stage of the ulcer you're looking at a particular patient, because your therapy is going to be directly tailored to the active stage in which you're looking directly tailored to the stage of the ulcer and the activity of the ulcer which you're looking at. For example, if you're looking at the stage of progressive infiltration and ulceration, you're going to step up, or you're going to have the ocular surface bombarded with epithelial with a lot of antimicrobial agents which would be epitheliotoxic here. Once you feel the infection is contained in the regression stage, then you're going to withdraw, or you're going to taper your antimicrobial frequencies, and you're going to add on adjuvant therapy, which is going to help in the healing. So that's how it's going to be important. And once it's come to the stage of scarring is when you're going to think about what is the residual visual acuity. Can you help this patient by giving glasses by refraction? Can you help this patient with contact lenses, or do you need to do a surgical intervention for this patient? So somewhere between this and this stage, your active ulceration and regression, if the healing starts occurring with thinning and with perforation, then you're probably going to add on or intervene using a surgical intervention in the early stages, and that's therapeutic penetrating keratoplasty. I think this is a basic understanding of microbial keratitis, whatever organism is causing the ulcerative keratitis. And once you understand this, this really helps you to manage your cases effectively. And for postgraduates, I think you no longer need to be worried when you're looking at an ulcer. So you look at what stage it is and you prognosticate your ulcer accordingly, talk to your patient accordingly, and you should know how long you need to wait, when you need to intervene, what are the type of interventions you need to give for these patients for effective healing of your ulcer. Okay, so from there, we move on to the next slide here. So history taking. So corneal ulcer is a is a frequent large long case in your exams here. So in your history, what all you need to cover? You need to ask for the risk factors which caused the ulcer here. You need to ask for ocular medications which the patient has been using earlier, either as therapy initiated by centers outside, or you're going to be asking about what other extraneous medications probably caused the ulcer. This largely, as you would think, if a patient is on steroid treatments, topical steroid treatments for allergy, if the patient is on anti-glaucoma medications for a long period of time, if the patient is a patient of severe dry eye disease, if the patient has had chemical injury. So these are all, scenarios which have particular risk factors for development of the ulcer. And if a patient is already on treatment, you're going to look at what is the compliance to the treatment which the patient is undergoing. So a quick look at the various predisposing factors. So I largely would encourage my residents to look at the risk factors under these 3 headings. What are the ocular risk factors? What are the systemic risk factors? And what are the environmental risk factors, largely being occupational in these cases? Yeah. So here, trauma, you always know that trauma is the leading cause for an ulcer to occur, whether it's going to be bacterial or fungal or acanthamoeba. Contact lens, where again, please remember in India, contact lens causes microbial keratitis, but it's not acanthamoeba. It could be other organisms as well in India. Then you have lid and adnexial infection. So these are all particular pictures. I'll be look at these pictures later. So lid and adnexial infections, and you're looking at patients who are having mebomitis. You have looking at patients who are having allergic eye disease here. So those are again lesions which are going to cause corneal infections here. Ocular surface disorders, as I told you, post-chemical injuries, cicatrizing diseases, chronic trachoma, OCPs. You can have patients with SJS, Sjogren's, primary Sjogren's, secondary Sjogren's. All these also have predisposed lesions to lesions affecting the cornea, as you can see in this particular picture here. So these are all cases that they are SJS, acute SJS, chronic SJS, who comes with epithelial breakdown and infections here. Allergic eye disease, yes, the commonest in what we see in our scenarios, and ocular allergy in whatever form you're looking at, but chronic VKCs, atopic keratoconjunctivitis, and Shields ulcers can get infected. So these are ulcers here. Then bullous keratopathy. So when you have compromised corneas from prior corneal diseases like pseudophakic bullous keratopathy, pseudophakic corneal edema, these corneas are again prone to infection and you can have a risk factor here. Topical medications, as I already briefed you, those on chronic topical therapy with steroids, anti-glaucoma medications, these are all surfaces at particular risk for infections here. Many prior ocular surgeries, so they can have wound infections and that can spread on and cause a dire infection affecting the cornea and the deeper tissues of the eye here. So that is in a nutshell. It's not a very exhaustive list, but by and large, almost contains all the important risk factors which can lead to the occurrence of keratitis. Then you look at systemic features. I think we all know diabetes, SJS, immunocompromised states, malignancies, patients with alcoholics because of malnutrition and extremes of age here. Occupational factors largely is farmers, gardeners, animal handlers. These are very frequent ones which come to us in our practice. But also remember all those who are working in labs who are handling or in contact with biological tissues, soil tissues are all prone to the risk of infection, especially if you're not able to maintain a good ocular hygiene here. So some of these are some of the representative pictures, and now we'll move on to the next one. Anything you want to ask by now? I think I can see only Ankita. Please feel free to stop me.
I think Sahil has also joined us. Sahil is also
Okay.
here.
Oh, okay. Please feel
Yes,
free
good
to
evening.
stop me. Good
Good
evening.
evening, sir.
So I think I'll stop and ask you questions when I come to something which is more, more pictorial, and you can describe it to me. Again, please remember to examine the ocular adnexa. That gives you a lot of subtle cues, and this can help you in making a very good, effective initial diagnosis. So, examining the ocular adnexa, examining the face, looking for viral vesicles, looking for other abnormalities of the lid like blink abnormalities, facial palsy, these can all lead you on to cues on neuroparalytic or neurotrophic keratitis. Look at if there's exposure keratopathy where the cornea and the conjunctiva is undergoing exposure, and this could lead to infection as well. Ocular adnexia examination, largely you will say meibomian gland dysfunctions, ocular allergic disease, trichiasis, entropion, ectropion, lacrimal apparatus affections here. So you can have a chronic dacryocystitis, you can have a discharge which is probably leading to recurrent conjunctivitis and corneal infections here. And again, then after you've completed all of this, it is important that you move on to your visual acuity assessment and a slit lamp biomicroscopy. If you really follow this protocol and this line of addressing your corneal ulcer, most of the time you would be able to pick up almost 90-95% of all the predisposing factors which have caused the ulcer, and you'll also be able to effectively examine your patient. Also, remember, identifying the source is very important in being successful in managing your ulcer. It's just not making a diagnosis of microbial keratitis, but if you want to heal it effectively, you also should know why that occurred and how you can probably tackle the source of the infection here. Simple tips is do not stain the cornea with fluorescein until the ulcer has been scraped. That really helps, and you scrape your ulcer. And but I think we usually don't follow these, and we do stain the ulcer first before we look at the scrapings. And prior to scrapes, apply anesthetic drops which do not contain preservatives. So again, these are simple tips, but usually not very practically applicable when you are examining our cases here. So that from here we'll move on to working up by clinical examination. So I always find the residents, when you're presenting cases, they jump directly onto the corneal findings. It's always a nice dictum when you're presenting your cases, start from the lid, the adnexa, and then you move on to the region of interest which you are probably talking about or your long cases pertaining to. So lids in corneal ulcers, you might have lid edema, you might have crusting along the lashes, you might see discharge, you might have a blepharospasm, which is very specific here. And blepharospasm is not to be mixed with photophobia here, so don't cross both here. So patients would have largely a blepharospasm because of the surface irritation due to the ongoing ulcer which is present. Conjunctiva could be ingested and could have edema. The conjunctival chemosis could also be present here. Then you go on to evaluate the details of the corneal ulcer in terms of elaborating or detailing the region of epithelial ulceration, the size of the epithelial defect, the size of the infiltrate, the depth of the infiltrate, how the margins of the ulcer look like, how the floor of the ulcer look like, the amount of necrotic tissue which is present, the surrounding stromal edema here. Look at the associated hypopyon, iritis, presence of KPs, and look at the pupillary reaction. Don't miss out on assessing the intraocular pressure, the lens status, and the posterior segment of the eye, because you can have endophthalmitis, you could have a pre-existing cataract in these patients here. So that's something you need to look at. And secondary glaucoma, always you would have most of the time you would have an inflammatory acute glaucoma in these patients because of the intense trabeculitis and clogging of the trabecular meshwork with the infective material which is being cleared off. So that's something which you would probably look at. And the raised IOP could be one of the most important reasons for the pain in the patient besides the pain due to the ulcer itself here. So slit lamp examination largely should cover the region of ulceration, area, density, the depth, the number of infiltrates, the size of the ulceration, the depth of the ulceration. And something which many times people forget is to look at the amount of corneal thinning which is present, because this is going to help you to assess during follow-up when you need to intervene by a surgical intervention or by other interventions other than just medical management of the patient here. You will need to look at the amount of surrounding stromal edema. Scleral involvement is also important, especially if you're looking at large ulcers here, and the amount of anterior chamber reactions and specific features which are pathognomic of say a bacterial ulcer or a fungal ulcer, a cantilever ulcer, like looking at dry looking infiltrates, feathery margins, presence or absence of satellite lesions and endothelial plaque, immune rings, fixed hypopyon, presence of pigmentation on the ocular surface infiltration. So these will also help you to assess and help to make you the right diagnosis for these patients here. Again, if you have areas of the cornea which is uninvolved, which is clear, then you could go ahead to check the corneal sensations in those areas. And documentation goes without saying is one of the most important aspects when you're looking at corneal ulcers. If you have access to clinical photography, that would be good. But if you do not have, I think it's best to put it on the case sheet, diagrammatic representations of how you would want to, how you would like to document the ulcer, so that on serial follow-ups, it helps you to make a diagnosis of the healing of the patient here. This is a picture which I think all of us know and all of us have seen, is that you look at clinical features of the ulcer, grade 1, grade 2, grade 3. So that is pertaining to the severity of the ulcer. So the size of the ulceration, it's not only the size, but the depth to which the stroma is involved, and the location or the area of the cornea which is involved, presence or absence of anterior segment reaction here, presence or absence of scleral involvements. These help you to grade your ulcer as mild, moderate, or severe ulcer. So less than 2, anterior 1/3 involvement only. These are merely mild ulcers here and do not have anterior chamber infiltrations and scleral involvements. Ulcers ranging between 2 to 6 will be moderate ulcers, and they usually tend to be deeper involvement involving up to the mid stroma. And these ulcers could be central and peripheral and will be associated with anterior chamber inflammations here. Sclera might not be involved in moderate ulcers, but then you have ulcers which are large, which meaning more than 6 millimeters. They tend to involve up to the posterior third of the cornea. They can be large and peripheral involvement. Hypopyon is always present, and the scleral involvement makes it more difficult to manage here. So prognosticating depends upon the severity of the ulcers you're looking at, and that's important when you are managing your patients here. So this, in a nutshell, is how your diagrammatic representation needs to look at, both in a slit lamp format and a head-on view of the patients here. I think this picture is self-explanatory. It talks to you about the superficial vascularization at the limbus, or the deep vascularization, the color coding for the region of the epithelial defect, the region of infiltration. So these, and remember always, the epithelial ulceration and the region of infiltration may not be coinciding. The edema might be restricted to just 2 millimeters around the ulcer or could involve the entire cornea here. The edema could be just simple epithelial bedewing, could have bullae as well here. The type of vascularization could be superficial or it could have deep vessels as well. Presence or absence of hypopion's here. So these are important, and if you have associated tissue thinning, that also needs to be depicted, best done on a slit lamp diagram, the slit lamp on a slit diagram as well here. So I think now we will go on to looking at how these ulcers actually are. Sahil and Ankita, are you ready, or you just? I'll quickly run through probably the therapeutic modalities or the diagnostic modalities you need to look at. All of us know that we have to investigate by an ulcer. The best investigation is to know what is actually causing the ulcer here. So a corneal scraping. So what you do in corneal scraping is to get a corneal smear. So that is how you need to make a smear on a clean slide. Slide is first, it could be cleaned with heat or with alcohol, with spirit, and then you mark on the undersurface of the slide the region where the corneal smear material is to be placed, and then you place the smear material on the top side within the region which has been marked on the underside here. So that's something you need to remember, and that's the right way of doing it. And you can place a cover slip over it if you want to look at a simple KOH mount, or if you want to do a gram stain GIMSA, you will do accordingly, stain these accordingly, and then have a look at it under the microscope here. You can heat fix your slide once you have applied the material so that it helps you better when you are staining here. Again, corneal scraping is largely diagnostic, but also can be therapeutic. So diagnostic meaning for taking a corneal smear sample for looking at the organism which is causing, and diagnostic for also for culture plating where you want to grow the organism which is causing the ulcer. So that's diagnostic scraping. But please remember, corneal scraping can also be therapeutic. It also helps to take out all the necrotic material which is present on the ocular surface, on the corneal surface, and debulking the necrotic material goes a long way in effective management of your ulcer with medical therapy. So sometimes you might need to resort to therapeutic scrapings every third day or fourth day, or a well done diagnostic scraping, including therapeutic scraping to remove the necrotic material, will also help you in good response to the initial antimicrobial management. That's a simple trick which you can remember. So let me see, this is playing. Okay, it's not playing here. This is again, this is I think one of our post-refractive surgery ulcers here. You can see we are trying to lift the flap here and go into the interface to get the material out of this particular ulcer. So simple steps is that make your patient more comfortable on your slit lamp and aesthetize the eye. You can use an eye speculum. And if you find the patient is more uncooperative, sometimes we do have discarded microscopes which are not useful for surgery. So you can make them lie down on a table and use these old microscopes, and they also help you to effectively scrape the ulcers. Please remember, do not send necrotic material for your microbiological evaluations. They will only come out with pus cells and no growth here. So you need to remove the necrotic material and then scrape at the leading edge of the ulcers here. And this is when you're going to get material which will have viable microbial organisms that can be grown here. Again, those ulcers which have been treated outside for a long period of time will not have viable microbial organisms which can be cultured. And that's largely one of the reasons why we are not able to get a diagnostic diagnostic culture results when we are looking at these patients who have been treated outside for a long period of time. Always basics, you would have your gram staining, you have your KOH or lactophenol blue staining for fungal hyphae, and special stains if you're looking at special ulcers or more like a xanthamoeba. Then you would plate on a blood agar, chocolate agar, sabrotes. Normally we do a nutrient agar and you would do a sabrotes texture for your fungi. And if you're looking at or suspecting acanthamoeba, then you're going to do a non-nutrient agars, E. coli, or for any other fastidious organisms. If you're looking at, you're going to look at plates. So I would urge all of the postgraduates to go back and revise. Till now, You'll need to revise your applied microbiology, go and revise your applied pharmacology. So these are two aspects which you need to be thorough when you are looking at microbial infections of the ocular surface or microbial infections affecting any part of the eye here. That really helps you to enhance your understanding and gives you a better way of managing your corneal ulcers here. I think scrapings can be done with with Chimera spatulas, or you could do it with your simple 26 gauge needles or little larger needles, your IV needles also, but be careful when you're using them, and use a fresh sterile needle for each type of scraping mount, scraping and inoculation when you're doing. Another way is when you're inoculating the nutrient agars, don't dip into the agars, but you will have to plate on the surface by simple C streaking, which will help you to identify along the streaks there would be growths which you are coming here. So any growth which is occurring extraneous to the streaking, you know that's going to be a contamination here. So these are simple tips which you need to look at. And by and large, I think all of you have read this in your microbiology postings. So this is just a simple brush up of how your slide will look like when you're looking at a gram stain for a diplococci, for a bunch of cocci, either whether they are bunching, whether they are in strings, whether you're looking at the cocci form, the bacilli form. In simple KOH mounts, you can look at fungal hyphae. They are very glassy, ribbon-like or a slender ribbon-like, and you will have to see whether they are septate, they are aseptate, acute, obtuse, branching here. And you would have nocardia, which is thinner, and now you also have pythium, which is more ribbon-like. And you can find acanthamoebasis, trophozoites when you are looking at your smear examination. So this is almost largely covers how your smear examination needs to be done. Again, pictorial representations of the various media. And we usually at our center transport the material in a transport medium because of the volume of cases which we have, which goes to the microbiological lab and the lab plates it. But the best method would always be a direct plating as and when you see your patient. And the direct plating is usually done for bacteria and for fungi here in two separate medias, as you're able to see here. And you will always wait for a week before you discard your fungal media. 1 to 2 weeks would be the time for fungi which would require growing. And you would probably hold it for 2 weeks before you say that it is a negative in terms of culturing fungal organisms. Yeah. So these are basic dictums when you are managing. Go back and revise your Jones criteria for diagnosis from culture. I think most of the time these are more textbookish and they're not going to ask you, but it's better to read about all these in any textbook which you are referring to here. Other diagnostic modalities which will help you in management of corneal ulcers. Again, this is a frequent question which is asked in your Viva. So simple ones is a corneal biopsy. More advanced imaging is in terms of in vivo confocal microscopy. I think missed out adding anterior segment OCT now is an important part in your managing corneal ulcers, and microbiological advances in terms of looking at PCR detections, next generation sequencing. So these are all come in a large way in helping you in diagnosing the various infections here. So that's how diagnosis has improved in these days. And when you need to do confocal microscopy is when you are looking at deep keratitis, meaning you look at ulcers which the epithelial continuity has resolved and you have ulcers in the stroma. Then it is in these cases where a confocal microscopy is going to help you to look at the morphology of the organism which is causing the morphology of the inflammation which is causing the infection here. And again, in refractory ulcers which are not responding to antimicrobial therapy, but remember when you're doing confocal, you will need a certain area of clear cornea and the patient needs to be comfortable to be looking at, needs to be comfortable for you to able to examine to do a confocal microscopy examination here. Again, microbial keratitis involving refractive surgery is where you probably will have to do an early confocal microscopy in terms of when you do intrastromal corneal rings, post-LASIK infections, if you have post-flap LASIKs and smile infections, post-incisional keratotomies. This is when a confocal is going to help you, give you an early diagnosis and help you to institute installation of early appropriate antimicrobial therapy for effective healing of your ulcers here. So that's when you use confocal microscopy. So I think this is just a pictorial representation of how you would be here. You could see the fungal hyphae present in the, you could see a lot of fungal hyphae in this particular confocal microscopy sequencing. Okay. And so KOH mounts, corneal biopsies in cases of corneal ulcer where you're not probably able to get anything on your scrapings, on your smears and your initial cultures. And don't hesitate to go for repeat cultures in these patients, sometimes if possible after a washout period of stopping the antimicrobials, if that is possible in your case. Otherwise, you can do a corneal biopsy here. Corneal biopsy could be suture biopsies, or you could use small skin biopsy punches to take out some amount of tissue adjacent to the ulcer and send it for biopsy in your patients here for cultures. And that will be when you are tackling with cases which are more virulent and it's not healing, and you want to have an antimicrobial diagnosis to enhance your management of your patients here. So I think I can stop here, and if Sahil or Ankit would like to come aboard and describe these for me. Yes, Sahil, would you like to tell me something or just give me a little descriptive
Uh,
detail on this particular? Yes.
Good evening, ma'am.
Good evening. Yeah.
What we can see is,
Mm,
uh, ma'am, this is basically, ma'am, we can start with the describing the lid and the nexa, where we could see uh, slight uh, slight discharging on the lid and the adnexa and the lashes,
mm,
while we see a central 5 to 6 corneal ulcer with some paracentral thinning, which appears to be impending perforation, and it has feathery margins.
mm,
And I can also see 2 hypopion,
mm,
and along with that there is congestion. Though,
yes.
yes, ma'am.
Yeah, so it's always nice to start when these are pictures. Sometimes they are shown in your Viva or your so you see it's a slit lamp biomicroscopic picture of a case of corneal ulcer. You can't comment much on the lids and the lashes because that's cut off from the picture here. But yes, you can see an inflamed lid margin. You do find conjunctival congestion, and as you rightly pointed out, there is a central region of ulceration with thinning, which is central and paracentral. You find adjoining infiltrates as well. You could see a few satellite lesions, and you have a feathery margin along with a significant hypopionia. So you make a diagnosis of a hypopion corneal ulcer here, or an ulcerative keratitis with hypopion is what's going to be your diagnosis for this ulcer. Okay. And largely you would refrain from giving an organism, because you could say this is probably a presumed mycotic, a presumed fungal ulceration given the characteristics of the ulcer. And you would probably need to confirm it by doing a corneal scraping for this patient. Okay. So do we have anybody, Ankita here, would like to try this?
Ashima, ma'am.
Ashima, sorry, Ashima.
Yes, ma'am.
Yes.
Ma'am, this is the first picture shows an ulcer showing dendritic uh, pattern of
Mm-hmm. Mm-hmm.
infiltration,
Mm-hmm.
and uh, the surrounding cornea appears to be clear.
Mm-hmm.
Mm. And the second picture, there's a uh, congestion with corneal uh, central corneal uh, abs- with surrounding central corneal ulcer with surrounding stromal infiltration and with a hypopion present.
Yeah. So here you find an ulcer which is largely seeming to involve only the superficial cornea. So this is a largely a superficial mycotic ulcer. If you catch your ulcers early in your fungal, this is how superficial mycotic ulcers will be looking at. They might have a pseudo microdendritic appearance here, but you can see the ulcers largely dry looking. These patients tend to be very comfortable on the slit lamp. So that's when you look at your correlation of your sign and symptoms here. Bacterial ulcers Small ulcers will be significantly symptomatic, whereas fungal ulcers, large ulcers will be less symptomatic here. So if you find something on a patient like this who's comfortably sitting here, he's a farmer, then you have your diagnosis dot on that this is a superficial mycotic ulcer. So, and this, if untreated, is going to go to progress to this stage, because at this stage, several times the patients would not probably feel anything unless somebody tells them there's something white sitting on their cornea here. And this is the stage when they start coming to you because they can see a large infiltration, and you can see it's a dry looking ulcer. It's a central ulceration. There's a dense stromal infiltrate which seems to be involving up to the posterior stroma, but without a slit, you cannot comment on that. You're having a lot of satellite lesions which are sitting here, and this seems to be a fixed hypopyon as well. So again, you're having more fungal looks in these ulcers. So this is how you have a variety of ulcers which look like fungal. Again, some of these are pictures where we have had culture positivity here. So that's why I'm confidently telling you what is different in this ulcer, Sahil. Here you can see the lid margins are edematous. Okay, there is a chronic inflammation of the margins. The margins are not looking healthy. You're having a circumcorneal congestion in this particular patient. But what's different in this particular ulcer?
There's central dense deciform ulcer.
Yeah, there is a central. I wouldn't use the word disciform.
Okay.
We usually reserve it for the disciform keratitis here. But here you are having a large central. It's almost like a corneal abscess.
Yes, ma'am.
It's like a large central dense infiltrate which seems to be involving the entire thickness of the cornea here. You don't have a stain on this, so you're not able to say how much of the ulceration, but roughly, if you look closely, you can see this is the epithelial continuity broken. So there's probably a large central ulcerative stromal infiltrate which you are finding as more like a corneal abscess. And what you find in this, you are having the surrounding 2 to 3 millimeters of cornea is surprisingly very clean. Right, so this is almost mimicking, and this kind of a picture you commonly get in staphylococcal ulcers. It's like staphylococcal abscesses in other parts of the body. They usually tend to be localized, and they usually do not tend to involve the other part of the other surrounding region. So in the eye as well, this largely is mimicking a staphylococcal keratitis. Here you look at a surface which is probably having some amount of spheroidal degeneration. It's having some amount of dry eye, and it's also having a deep infiltrate, and you can find there is thinning out here, and probably here it's having a little thinning, and there's a lot of necrosis. And this could probably be the ulcerative region, or then if you stain, this is the region which is going to stain here. Again, because we did get cultures on this, these are again fungal ulcers, so they could look differently when you're looking at a variety of fungal ulcers here. This again, the one here, do I have Ashima with me? You want to try this, Ashima, again?
Ma'am, this is a ulcer and in the it shows pigmentation
So the
and
lower one here, yes, you're having a large ulcer,
a
and you
large
can see,
ulcer.
yes, you can see a significant brownish pigmentation. Sometimes you can see blackish pigmentation. So what does this tell you? This one look is enough to tell you what the ulcer could be. What do you think this would be? What type of fungus will this be? Commonly,
Parvularia.
yeah, Curbularia. Okay, good. So Curbularia is a microbiological diagnosis. So I don't think we have microbiological vision now. Yeah. So if would you like to classify what are the corneal pathogenic fungi which you would commonly encounter?
Yes, ma'am.
Ma'am, they can be we can classify them as
Hmm.
septate. No, ma'am.
Hmm.
First,
Hmm. Okay, septate and aseptate is the
aseptate.
morphology of the fungal
Ma'am,
height.
we can basically classify them as morphological classification based on like yeast like
Genetic.
diamond.
So you're going to look at filamentous fungi are largely the fungi which are corneal
Yes.
pathogenic. You might have non-filamentous fungi. You can
And
have yeast-like organisms, yeast and yeast-like
yes,
organisms. And here you have, this is a dermataceous fungi. So when you
pigmented
have this
dermatitis.
pigmentation, you know largely. So now go back and revise your applied microbiology. So it helps you, once you have this diagnosis in your mind, here you can see it's a typical dry-looking small central ulcer with a large satellite nodule. right? This could be aspergillus most commonly here. And here you're having a very large ulcer, you have a hypopyon, then these ulcers tend to be more virulent, thereby dermatitis fungi. So go back and now and revise your what all fall under filamentous fungi, what all falls under non-filamentous fungi, what all falls under dermatitis fungi. So this differentiation is largely important because if you're looking at a very virulent growing ulcer, you would know whether it's fusarium, and that helps you to decide which antifungal treatment you need to give for your particular patient here. If you're looking at an aspergillus, and I know it's going to respond well to your natamycin or voriconazole. If you're having a fusarium ulcer, you have to probably move it out and use a amphotericin B, and your voriconazole is not going to respond well to fusarium ulcers here. Your fusarium is not going to respond to voriconazole. And if you have dermatitis fungi, these are ulcers where probably going to be very difficult to manage. Their antimycotic MICs are much, much higher. And you will probably need to add on amphotericin for these patients. And you will probably need to use some of your newer antifungals. And if you have yeast-like organisms, you have candida, then you're going to use fluconazole. You're going to use echinocandins, which are available now, caspofungin, micafungin. So that is how your initial impression is really going to help you start the right antifungal treatment here. So that's important in the way you're looking at these ulcers here. Again, more fungal looks here. Look how different here. Here it's just like a superficial mycotic ulceration. You don't find so much of infiltrates. You have an ulceration which is presenting here. Here you have a dry looking ulcer with multiple satellite lesions. Again, these are more fungal looks which you can get on your patients here. So as I already briefed you, the important is what you need to start, whether you want to start your polyenes, whether it's small molecular polyenes or large molecular polyenes, largely being either natamycin or amphotericin is what we have with us. Whether you want to add on azoles, which azole you would like to use. Largely we have only voriconazole, but we have done a study using posaconazole now. So posaconazole is also very effective, specifically that if you're looking at refractory ulcers, because its antimycotic spectrum is larger and its MIC is the lowest compared to all the other azoles which you have. And also considering that voriconazole is now giving a higher amount of resistance, most of the antimycotic have started developing resistance to voriconazole as well here. So this is important. And addition or starting amphotericin B is also something which would help. And again, remember, natamycin is fungistatic and amphotericin B is fungicidal. So I would again reiterate, please go back and revise your microbiology. Otherwise, it tends to get a little boring when you're talking about ulcers. Ashima, I'm going to come back to you and ask you, can you describe this for me?
Mm. Yes, ma'am. This is a uh, ulcer involving central cornea with vascularization
Yeah.
present.
So you're having a large vascularized. Is it an opacity or an ulcer?
Oh, so, ma'am, it looks like an opacity.
Are you sure? Sahil?
Ma'am, it looks more on the lines of opacity to me also.
Okay. So here it's more like this is what we see as an ulcer which is healing,
Healing
right?
also,
So
yes,
this is probably I would take it into a stage of regression, but the
yes.
complete cicatrization or scarring has not occurred because you can see regions of activity here. So you can see some activity here, you can see activity here. There's activity in the deeper stroma, and you have vascularization which has gone probably mid stroma or deeper in this patient. And this is a patient who's having inflammation and infection for more than 6 to 8 weeks here. This is when the superficial epithelium has healed, but there is chronic smoldering infection and fungal keratitis, right? So because your deep mycotic stromal infiltrates and your endothelial plaques are not healing, please remember all your antimycotics available will be able to penetrate the cornea only in the presence of an epithelial defect. So that's when I said scraping is not only diagnostic, but it's also therapeutic because it creates a defect and it helps your antimycotics to penetrate. So once your epithelial continuity is closed, is restored, then your antimycotics do not effectively enter. And if you have a chronic smoldering infection such as this, where your deep mycotic and your deep stromal infection persists, or your endothelial plaques have still not totally gone away, this is a stage when you probably can resort to using intrastromal injections here. So this is when I would use an intrastromal injection. That's when you're probably going to take your antimycotic agent closer to the region where the antimycotic is not reaching. And that's, I reserve most of my anti-intrastromal infection injections for such cases. Or you have a large endothelial plaque, you have a large non-responding exudate in the anterior chamber, then an intracameral wash will really help in these patients to take out your infection here. So these are adjuvant treatment modalities or interventions which you would like to plan when you're managing your keratitis. Here you have more looks here, and these are cases where probably here you can see a very dense endothelial plaque and anterior chamber exudates which are sitting stuck to the cornea and the endothelium of the cornea. So intracameral amphotericin washes, if you have your antifungal, if you have your fungi culture sensitivity, it really helps. And this is a case where probably an intracameral injection will, or intrastromal injections will also help in these patients here. Okay. So you have more looks of these fungal ulcers and see how it started off and how it heals out over here. Yeah. Okay. So Sahil, can you talk to me about this ulcer?
Ma'am, on the left is a slit lamp photo
Mm-hmm.
of ma'am, almost central to paracentral corneal, I would say, the ulcer in the resolving state. From what I can interpret, there's blunting of the margins,
Mm-hmm.
and the congestion seems relatively the resolving stage, and the central, the paracentral ulcer is up to 5, around 4 to 5 mm in size, and there is central more dense, opaqueness in the center that could be the site of the ulceration. And besides that, I see the remaining cornea, the other peripheral cornea part is clear,
Okay.
so it could be in the resolving stage.
Okay. So this is a patient who came to us following a 5-day history with acute pain. So now I think you would like to change what you looked at. It's not on a resolving stage. It's a 5 days contact lens use here. This is a small central infiltrate. This is an immune ring which you're seeing surrounded here. And the diagnosis clinches when I say when the patient was using contact lenses. Yeah. It was very painful, right? So this, of course, is one of the looks of an early acanthamoeba ulcer when the patient came to us. The second one, which you see a very florid inflammation, there is a ring infiltration. Yeah. So you can see a very, very characteristic ring abscess in the stroma. You have a superior breakdown here. Probably this whole region is the edge of the epithelium, which you're seeing. So there's a central large ulcer, which is seen here. This again clinches a diagnosis of an acanthamoeba ulcer here. Please remember, Pseudomonas can also present similarly. Again, Pseudomonas presents very early with just a 2 to 3 days history like this. There could be contact lens use, there could be trauma in these patients here, but when they have, and they have a very rapid melt in Pseudomonas. Within the next 3 days, you would find almost an entire stroma melts away, and you'll have to do a early therapeutic here. So both these cases in this particular case are cases of acanthamoeba ulcers. I'm just showing the different profile of acanthamoeba. This is when the patient presented early on to us here. And this is a patient who was using bandage contact lens for a long period of time for pseudophacus pillus ketopathy, and landed up and came to us with this ring abscess here. And both of these were culture positive on acanthamoeba for these patients here. So that's how, when you really look at and look how the morphology is different on these ulcers, it really helps you to make a diagnosis of these ulcers here. So here again, you look at acute ring abscesses here, and it need not always be acanthamoeba. You can get ring abscesses in other microbial organisms as well. You can get them even in staph and strep as well. But commonly you would look at Pseudomonas and acanthamoeba. When you look at here, you're looking at a nice central necrosis with thinning, and this would probably rapidly progress to a perforation as well. So these are ulcers which you need to look at and call them more frequently here. Here again, you have a large ulcer with a very thick, dense endothelial plaque, which you can see in this particular patient here. And again, a ring abscess and melt, and some of these would have fungi coexisting with acanthamoeba. So that's something which you also need to look at when you're looking at a non-resolving fungal ulcer. You have more of stromal abscesses. These are very typical staphylococcal looks here. very angry looking eyes, symptomatic patients surrounding cornea is effectively clear. These are staphylococcal looks here. Again, this I think due to shortage of time, I will just quickly run through these. Here you can see one healing edge and one active edge of the ulcer. So this is Ashima. Okay, streptococcal ulcer.
Yes, ma'am.
Very
Thank you.
characteristic. Very usually rare to get some of these pictures, but here you can see a healing edge and a progressive. So these would be streptococcal ulcers. I think you cannot miss this. What is the left one? What's the right one? Here you can see a little amount of mebomitis. You're having blood vessels coming in. So here these two are
And
varying presentations of, yes, Sahil.
staphylococcal peripheral
Yes,
ulcer,
blepharokeratoconjunctivitis is what you're saying. And
blepharokeratoconjunctivitis.
yeah, so you could have staphylococcal toxins which are colonizing on the lid margins, and they tend to produce immune abscesses on the cornea. And remember, if you keep treating this as infective ulcers with fortified antibiotics, they're going to progress very fast and land up with the peripheral ulcerative keratitis and perforation. This is a scenario which will respond using steroid management here. So that's when you should not look at all ulcers as infective ulcers. You will also have to look at when they're associated with a neck cell pathology. You're probably going to keep in mind the need for immune ulcers, which will also be there on these patients. So these don't require scraping also. You will not get anything on scraping because these are immune abscesses which you are seeing here. This one, very characteristic. Anybody? Ashima Sahil? Cannot miss this. Is a textbook picture. It was lent to me by my friend here from the south. You see this more commonly, and in the north, you do not see so much of this because by the time it comes to us, especially in tertiary care centers, is meddled quite a bit. But if you see this early on, this is very, very characteristic.
In the chat box, I think Priya and Prachi has written this as nocardia.
Absolutely. So, would you like to describe this presentation?
Breathe like that.
Yes, absolutely. It's like pearl. It's like a pearl ring of pearls or a wreath-like pattern here, which you would see, and this clinches your diagnosis of nocardia. It would present very much like a fungal keratitis, and patients might have, history of contaminated soil or contaminated water, common in these children who play football on red soil. So this is a very, very common in the south here, and it's nocardia, and you need to recognize this, the string of pearl or the wreath-like appearance here. So I think I'm probably going to close with this one for you. But what's different in this ulcer which you're seeing? Anybody wants to try?
And this it could have a peripheral extension, limbus
Yes,
involving
it's a severe ulcer. It's almost
severe ulcer.
involving two-thirds of
Mm.
your cornea, more than 50% of your cornea. Seems to be deep. You could see some amount of this whole region is probably having an epithelial discontinuity. You can see thinning in the center over here. Yeah, so I would probably place it as a bacterial ulcer, but what's significant is it's having approach almost 4 to 5 clockers of scleral involvement here.
Yes,
Yeah. So when you see ulcers like this, it's largely secondary to endophthalmitis. So when you have your scleral involvement, you would have a primary endophthalmitis, and then when the infection is uncontrolled and spreading, but largely gets missed and gets diagnosed as an corneal ulcer with endophthalmitis the other way around here. And if you go and do a therapeutic keratoplasty for this, you will end up burning your fingers because that's going to again get a very rapid reinfection. And unless and until you have a microbiological diagnosis on this and you're having a culture sensitivity, do not take up such ulcers for a surgical intervention here if you're hoping to have a good management outcome in these patients here. I think these are more pictures I want to try. I know it's a little more difficult. Yeah, it's not a very clear picture. You can see a gram-positive cocci in this staining. This is very characteristic. Find
Filamentous
septate
fungus.
fungal hyphae or stained corneal smears, and this is a KOH mount where you're able to see the fungal filaments here. This one is thinner filaments here. If you want to go back and see there you saw broader filaments and they are septate and they are branching. And it's a little difficult to make out on your KOH mount, but here you could see these are thinner filaments in comparison to and these are nocardial filaments. Of course, now you have pythium as well. So I think I'll stop here. I thought I'll cover viral also, but I think we're almost out of time. We have 5 more minutes for those if you want to ask any more questions. I have largely refrained from making it a very didactic, boring lecture because all corneal ulcers tend to get very boring if you are, really talking about just ulcers all the time. So I thought a learning module will really help you to enhance your knowledge on how you can diagnose the ulcer effectively. That's the difficulty which I find most of the residents have, especially senior residents. That they always find that they know it's an ulcer, but they do not know what to do beyond it. So that's the learning which, because you need to have, as most of the ocular casualties are manned by the senior residents or senior postgraduates, and making a good clinical diagnosis, whether it's presumed bacterial, presumed fungal, presumed viral, is something which is very important. I think what I would urge you to go back and read about the classification of the corneal pathogenic fungi, read about the classification of the antibacterials which are commonly used in management of ocular infections, and how antibiotic resistance has now changed. What is the first generation, second generation, third generation fluoroquinolones? Fungal, it's pretty much easier. You don't have much to read about, but do go back and read your classifications on antimycotics. What are polyenes, small molecule, large molecules, their mechanism of actions, their side effects here. What are the newer antifungals which you have, the echinocandins which you have, when you need to give yeast, what is effective against yeast and yeast-like organisms here. So that's what you need to know. I've largely refrained from covering acanthamoeba, but again, for acanthamoeba, we do not have a lot of anti-acanthamoebal drugs, but it's nice to go back and read your classifications of biguanides, propamidins, their mechanism of actions here. Then you also have newer antiseptics in terms of chlorhexidine, which also helps you. Some amount of these anti-acanthamoebal activity is exhibited by voriconazoles. The azoles also do help you in managing some amount of your fungal infection. So that is by largely mostly textbookish. So I've refrained from putting those tabular columns for you, and I would urge you all to take this as homework from today's class. And I think if you revise this, your knowledge on bacterial, fungal, acanthamoebal is largely covered.
Yes, ma'am. I think we can have a question for the quiz. So first two people who would answer in the chat box would get a prize.
You want me to give the question?
Yes, ma'am. Yes, ma'am.
Okay, so just give me a minute. I'll open up something else for you so that I can show you. What do you want? Do you want a picture, or do you want
Anything, ma'am.
microbiology?
Anything you can
Anything?
ask. Yeah.
Anything? Okay. So okay, I need to share my screen again. Yeah. Recording. I can't see my screen. I can see it here. Okay. Okay. You can see my screen?
Yes, ma'am.
Yes?
Yes, ma'am.
Yeah. Continue. It's okay. So what do you need to do for this particular picture? The one on the right, I've already given you a diagnosis, so I didn't want to ask you on the diagnosis. It's a necrotizing stromal keratitis. How would you manage this case? Anybody?
So you have to type in the chat box.
Oh, I can't see the chat box. Where's my chat box?
So we have
Chat box.
two answers from Ankit as therapeutic keratoplasty and Roshali as keratoplasty.
Okay.
Prachi has said tinonplasty.
Okay. I think I would accept all of it, but what do you want to add on this other than therapeutic keratoplasty? I think Sahil can tell us. Will a therapeutic keratoplasty be the last resort? Always give antivirals. This is a necrotizing stromal keratitis,
Yes,
which
Sahil has written antivirals. So, ma'am,
yeah,
whom do you think we should pick
Sahil.
up? Sahil. Okay.
Sahil.
Right.
So we have only one winner this time, Sahil.
Mm.
So thank you, ma'am, for taking such a nice and elaborate class on infectious keratitis. I think we have largely covered the bacterial and the fungal part. So it was nice, and I think it was a nice interaction between Ashima and Sahil. So thank you everyone for being with us, and we have to have more Kaksha like this. Thank you,
Yeah.
ma'am.
Can I ask one question?
Yes, please.
Ma'am, based on like your work also, like all the in cases of like susceptible corneas, like any post corneal procedure case, like you discussed post LASIK, post keratoplasty, and there have been some like in dystrophies with cornea. Like if any infection occurs, like especially in the post-op cases, like they might require steroid. So, but then the infection and the interplay between antibiotic and steroid in that case, like in
You're talking about a post-refractive surgery keratitis.
post-refractive, post-keratoplasty, ma'am, if like fungal corneal
Post-keratoplasty.
ulcer, after that, if it recurs, and at that time steroid are also required, or ma'am, in that case, how do we decide what to uh, give more and how do we
Yeah.
titrate?
See, if you're looking at let's say a post-therapeutic keratoplasty or a post-optical keratoplasty infection, when you're treating infection, you always withdraw your steroids. And once you've contained and your infection has started healing, if it is not fungi, if it is not Pseudomonas, then you can give a steroid therapy monitored. But if you're looking at post-refractive surgery interface infections,
Yes, ma'am.
when you're looking at interface infections, I think it's always best, especially you're looking at eyes with potential 6/6 vision. You treat them for the infection and not steroids.
Yeah.
Yeah.
Thank you.
Do we have any other questions? No. Thank you, ma'am. I think you were also not well. I could assess that you also have
got
cough
a
and
bad
cold and
viral,
yeah,
got a
bad
bad
throat.
viral and just about
Yeah.
overnight. Yeah. I hope I'll get better in the next 2 to 3 days. It's a long weekend, but it spoiled our weekend. Wishing you all a wonderful Independence Day, and thank you, Ankur, for having me with you. Ankur has always been a special friend, one of the most, one of my best junior residents, and I always love interacting with him. Thank you, Ankur, again. And I wish all the students a wonderful Independence Day and enjoy a long weekend and happy learning.
Thank you, ma'am. And
Thank
thank you everyone who joined us. Thank you.
Thank you.
Thank you. Good night.
Good night.